So the main goal of the minimal invasive spine surgery is, of course, to achieve outcomes that are comparable to previous standard macro or microscopic techniques, but enabling patients to do a faster recovery. So these are the highlights of the minimal invasive techniques. So smaller incision, less tissue damage, but of course with the use of the adequate instruments, magnification, or standard use with the operative microscope, and of course with good visualization of the procedures. But still, microsurgical procedures, especially in degenerative disc disease, talking about the dissectomies, the microsurgical dissectomy remains the golden standard. The advantages of minimal invasive techniques could be those that you can see on the slides. Achieving less or goal is the less post-operative pain, faster recovery of the patients, more quick dismissal of the patients from the hospital, and of course minimal blood loss, minimal development of scar tissues. Again, this is combined with smaller skin incision and minimal less damage to the paravertebral muscles. That is actually can be compared or can be connected with less post-operative pain that the patients are feeling. So the advantages is the shorter post-operative hospitalization, one-day surgery, or even going admitted or released from the hospital on the first post-operative day, faster rehabilitation, of course, faster return to work and everyday activities. And regarding the economic aspect, this could be and must retain into the cost-effective intervention. Advantages for some active sport life is when you preserve the facet joints, you preserve the stability after let's say removing only the fragmented sequestered disc fragment, and when you preserve the intradiscal tissue, then of course those patients will recover faster and they can achieve normal functional life in shorter time period. Contraindication for such indications, minimal invasive indications, are these ossified disc protrusions, central stenosis, and of course spinal instability. Disadvantages could be the X-ray exposure that the surgeons and their team is exposed to, and of course the learning curve that is usually steep, and sometimes the financial aspect is important because those instruments have to be ordered, have to be paid for. And regarding those, one should know the anatomy, proper anatomy knowledge. Of course, those minimal invasive exposures are always more narrow than the standard procedures, and with time the surgeon get its skills regarding the minimal invasive techniques. So we using in our department those techniques that you can see on that slide. So let's start with the less invasive one. It cannot be called an operative invasion. This is more a procedure. It's a radiofrequent ablation of the facet, denervation of the facet joints. Our experience it reduces lumbar pain, especially in cases of degenerative disc with no clear sign for surgical interventions, but in patients that experiences low back pain. We did not have any postoperative complications regarding especially the injury of the spinal root exiting near the facet joint, and patients are more or less satisfied. So let's say 60-70% of patients had good results. In 20 to 30% of patients, they did not achieve any amelioration regarding the RFA. These are the slides showing how the procedure is done, as you will all know. And in some literature review, it says in this work that the majority of the studies focusing on lumbar face joints and sacroiliacal joints suggest that the RFA significantly reduce pain, but in short-term follow-up. Then we move to a little bit more invasive techniques, and this is the PLDD, or the percutaneous laser disc decompression, that was described by Choi in 1986. Our experience with that let's say 8% of patients that we tried doing the PLDD could not go through the procedure under local anesthesia. It was too painful for them, or they developed some vegetative signs like vomiting or low blood pressure that enable them to continue the procedure. 12% did not experience any benefit after the intervention. We didn't have any CSF leak after the procedure, but of course, when you do the PLDD, especially the L5S1 level, you are passing near the dural sac. So in number of patients, there is an intra-procedural CSF leak, but after that, the correction of the needle trajectory is done. But after the operation, we did not have any past any CSF leaked. But again, in those patients that had CSF intra-procedural, we did, and they did in some, let's say 5 to 10%, they did experience the post-punctural symptom due to some CSF leak that actually passed on rest and some caffeine uptake. 80% described that they had reduced leg pain after the procedure or reduced low back pain. Regarding the comparison between the PLDD and conventional microdiscectomy, studies suggest that the PLDD is a relatively safe procedure, and that results in non-inferior outcomes. Let's say after 1 year following PLDD, can be compared with surgical results, but this is only in let's say contained herniated disc. PLDD made that the surgery could be avoided in 48% of those who actually were candidates for surgery. And the conclusion is that really in a contained, let's say, a dorsomedial lumbar disc herniation or protrusion that are producing dominantly low back pain without irradiation into leg, PLDD actually can be a first method of choice in treating less invasively those patients. We then move to the tubular microdiscectomy. We are using this kind of system, as you can see on the images. I can show you a short video making a discectomy through the tubular dissector. So you can see that the proper placement of the disc should be made. I skipped the video, so you see at the end the skin incision that is always like 2.5 or 3 centimeters. At the end, intraoperative pictures, there is a disc protrusion. This is the decompressed nerve root, and of course, at the end, the skin incision. Our experience with the tubular microdiscectomy, we have CSF leak in 2 patients. We did not experience any wound infection or signs of lumbar discitis, but in 4% of patients, they had to be reoperated due to the residual herniations or recurrent herniations that happened at the same level where the matrix was applied. So again, comparing into the literature, the reoperation rate was 18% in the tubular discectomy and 13% in the conventional discectomy. And the long-term functional and clinical outcome did not differ between patients with standard discectomy and the tubular discectomy. Also, This study from Germany said that the technique is equally effective and safe treatment option for recurrent lumbar disc herniations. The next minimal invasive technique that we are using is the full endoscopic discectomy. This can be done transforaminal or interlaminar. Transforaminal incision is always done on the lateral using the Cumbin's triangle as the landmark, and is done approaching laterally, transforaminally, as you can see on the slides. For the interlaminar approach, we're using always on the L5-S1 segment because of the anatomy. As you well know, we cannot approach this segment from the lateral segment because of the iliac crest. So the interlaminar approach is done like you can see on the pictures for such disc extrusions with sequestration, with fragmentation. And this is the short video showing the procedure, interprocedural video, making the approaching to the spinal canal, to the endoscopic working channel. Let me just see if I can speed it up a little bit. So now we are approaching to it. We are removing the yellow ligament, the ligamentum flavum, and we soon gonna be head to the spinal canal. There is a little bit of the bleeding that is stopping on irrigation. And now you can see the removal of the disc that is compressing the nerve root. Nerve root is displaced on 12 o'clock. It's underneath the working canal. Here is the some fat tissue. There is, of course, always a matter of visualization, of obstruction. Lots of irrigation has to be used. This is now working around the nerve root and making sure it's not underneath the working tube. And this is the disc fragment that is now coming out beneath the spinal root. And now we can take it with a clamp and put it out. In that case, we actually decompressed the spinal root. And in hands of the experienced surgeon, the full endoscopic lumbar discectomy shows some actually great results. But again, compared with open lumbar microdiscectomy, the endoscopic discectomy showed the higher incidence of residual disc or incomplete decompression. But in terms of operation time, complication rate, and incidence of recurrence and reoperation, the PLDD can actually doesn't show any significant difference in comparison to the open discectomy. And of course, it can the shorter hospital stay and shorter time of return to work is achieved. Again, no difference was found in overall complication between the lumbar microdiscectomy and endoscopic discectomy. So in our institution, we compared three techniques: the tubular discectomy, classic discectomy, and microdiscectomy in our patients. You can see that in each group were around 20-25 patients. We compared and evaluated the OD and the VAS scale before and after surgery, and with the follow-up even 5 years from surgery. And these are the results saying that, again, there is no statistical difference between the methods used. Maybe the let's say this standard microdiscectomy is showing in the long-term follow-up, is showing better results comparing to the tubular discectomy or the macro dissectomy, and this is actually can be compared with the literature that is found with let's say that results and the rates of any complications did not differ, but in minimal invasive dissectomy, the higher rate of intraoperative nerve root injury following percutaneous procedures can be relative to the minimal invasive dissectomy. So in this group, giving the potential advantages, the minimal invasive dissectomy can achieve relief of leg pain, then lower rehospitalization rate. And in regarding to the surgical site infection, you can see here that there was no difference between the techniques applied. The spondylodesis can be done in minimal invasive stuff, but this is now not the topic, and it will exceed the time that I'm consuming. And in conclusion, if you carefully select your patients, then it is, and you choose the right methods, the right surgical methods, and you have experience in doing tubular dissectomy or endoscopic dissectomy, we experienced that the tubular dissectomy groups were better in the short-term follow-up, but the standard microdissectomy in a longer follow-up had better results. Longer follow-up, of course, is still needed for better analysis of these different surgical techniques. But actually, we are still in favor of minimal invasive spinal procedures, especially in good selected patients, because it offers the patient a quicker hospital admission and faster recovery. And I thank you for your attention.